Welcome to Doc podcast. My name is Abbas Shafi, gastroenterologist.
And I'm Rob Hoyer, medical oncologist.
This is a podcast about lifestyle medicine, disease prevention, and longevity.
This podcast is provided for informational purposes only. It is not medical advice. Please consult your physician for individualized therapies. Hi there. Welcome to today's podcast where we're going to talk about the pancreas and pancreas diseases, including pancreas cancer. I'll let my good friend and colleague Abbas kick it off with a discussion about the anatomy and function of the pancreas. We're so happy to be recording again in person. And Abbas?
Thank you, Rob. The pancreas is located behind the stomach in left upper abdomen. It is a solid organ which is surrounded by small intestine, liver, and spleen. It is spongy in nature, and it produces both exocrine and endocrine to help digestion, as well as will regulate our blood sugar. To understand the function of the pancreas, we need to recap the digestion. As we eat food and break it down by our mouth and transfer to the esophagus, the first encounter in the stomach is by multiple enzymes as well as acid to break down the food, and subsequently this food, when it's liquefied and broken down, moves to the duodenum, which is the first part of small intestine. While there, the pancreas as well as bile, by producing bicarbonate, the severe acidity of the stomach content get neutralized. Pancreas produces about 1.5 liter of bicarbonate as well as multiple enzymes. These enzymes are break down the certain particle of the food digestion, as well as the fat. Each enzyme that is produced in the pancreas is in pre-packaged form, and then get activated in the beginning of the small intestine.
Abbas, I just wanted to clarify. Did you say 1.5 liters of bicarbonate? That's a lot of fluid.
That is correct. That's an estimate. Of course, individual is different, but the pancreas produces large amounts of pancreatic juice, mostly the external pancreas, and that has, beside bicarbonate, many the digestive enzyme as well. That plus the bile that starts from the liver and stored in gallbladder enters the duodenum at the same time, and that's somewhere between 200 to 600 ml per day. This combination of this will neutralize the stomach acidity. This way we do not have duodenal ulcer or damage to the small intestine. As you know, further down the small intestine, the pH is neutral once you get to jejunum and ileum. So this is, yes, correct. This is large amounts of enzymes. And the exocrine enzymes are multiple, like trypsin and chymotrypsin. This breaks down the protein, amylase for carbohydrate, and lipase for fat. So this way, the further breakdown of the food content that we have, these are all prepared for absorption as a cellular level. So further we can use them for energy in our body.
Abbas, we hear a lot about diseases of the pancreas, like pancreatitis and endocrine problems. Could you describe a couple of those? Sure.
Let's go back a little bit. We'll talk about the endocrine function, and then we'll tie it all together. Commonly, 95% of the pancreas is the exocrine, and the 5% that function as endocrine, which means these are hormones. They're not secreted to the small intestine, but not to the blood. And that's mostly insulin and glucagon. Insulin in our body decrease the blood glucose and allows the glucose to enter the cell. And glucagon does opposite. It raises our blood sugar. The proper management of the blood glucose is essential for most of our body organ functions, such as brain, heart, kidneys, liver, as well as any other cells in our body. Some of the common disorder of the pancreas that we see is pancreatitis. Pancreatitis means the inflammation of the pancreas, and that can be acute, meaning suddenly happening, or can be repetitive and cause chronic pancreatitis. The acute pancreatitis, mostly in Western culture, is alcohol, followed by bile stone or by bile crystal. But however, if you look at the text with many other etiology, which is considered less than 10% of that, can include medicine, trauma, elevated triglyceride, which is one of the lipids, spider venom, as well as many other things can cause the remaining of the acute pancreatitis. But majority is the alcohol and biliary sludge or biliary crystal can cause that.
Just curious about pancreatitis, and it's really interesting about the spider venom. I didn't know about that one. How much alcohol is it? Is it more of a amount of alcohol in drinks or grams that will cause pancreatitis, or is it different for different individuals?
It's mostly we see it in binge drinking. So to produce pancreatitis, you need at least have 6 drinks in one setting, and commonly when people drink intermittently, they produce large amounts of excretion at one time, as well as many secretion include a lot of mucin as well as other protein. Then consequently they get a temporary probably pressure buildup in the pancreatic duct and cause the activation of those enzymes. When those pancreatic enzymes involved, these are made for digestion of the food, then start digesting the pancreas and causes acute inflammation with these enzymes, as well as the triglyceride and other type of the fatty necrosis around the pancreas, and that's consequences develop acute pancreatitis. The repeated alcoholic, they get intermittent pancreatitis, and then subsequently will end up with chronic pancreatitis, which can cause both exocrine as well as endocrine insufficiency. The other causes of chronic pancreatitis sometimes is familial and inherited. The other one sometimes we see with autoimmune pancreatitis, which is more of an autoimmune disease, and the treatment of those are longevity for enzyme replacement, as well as close monitoring of the blood glucose and replacement with insulin, as well as sometimes the blood sugar is too low, they need to carry glucagon with them as well. The chronic pancreatitis or exhaustion of the endocrine can cause diabetes. If this is for our consumption of the food, then pancreas try to produce more insulin, but then the downregulation or exhaustion of the receptor, that's called type 2 diabetes. However, the type 1 is when the pancreas does not produce adequate insulin. That could be juvenile onset or adult onset. And those people, they need insulin replacement for monitoring or keeping the glucose appropriate in their blood vessels. Beside the acute and chronic pancreatitis, as you know, there are other disorder of the pancreas, which commonly these days we see them sometimes incidentally on the imaging, but sometimes, of course, based on the patient's symptoms. Rob, can you go through some of the finding on this benign versus neoplastic or malignant masses that we see in the pancreas?
So there are quite a few of these, and these are something that we do encounter fairly commonly in clinical practice. A lot of times these are picked up on imaging, either CT, which is a CAT scan, or MRI scan of the abdomen, and we'll see a little mass in the pancreas. And of course, we need to figure out what it is. Is it cancer? Is it or what we call a pre-malignant tumor of the pancreas? There's two that we see most commonly. One is the mucinous cystic neoplasm, and that's it's called the body and tail of the pancreas, and that's often most seen in women between ages 40 and 50. And another one that we see also pretty commonly is called the intraductal papillary mucinous neoplasm, what we call the IPMN, and that's occurs in the head of the pancreas usually, and it's found in both men and women, in older men and women, 60s or 70s. There are also what's called neuroendocrine tumors of the pancreas, and these can be both benign and malignant. And some of these are secretory and some are not secretory. So some of the things that Abbas was just talking about with the insulin and glucagon, these neuroendocrine tumors can actually make. And so, for example, there's what's called the gastrinoma, which secretes a hormone called gastrin, and that can cause ulcers in the stomach. There's something called an insulinoma, which can make insulin. And there's a glucagonoma, which can make glucagon. And this, just by the way, this is, so Steve Jobs had a neuroendocrine tumor of the pancreas, which was malignant and spread to his liver. That's why he needed to get a liver transplant. Just wanted to mention that. But these are oftentimes slower growing tumors of the pancreas, and usually can be cured with surgery if caught early.
Yeah, a lot of times we get a referral from the primary care or radiologist, and patient panics that they have a mass in their pancreas, and of course everybody worries about classic pancreatic cancer. But even these are very rare, but these are all have to be investigated and make sure that all of these growths are whether benign. Benign means these growths are instantly and very seldom they grow, but some of them potentially for slow malignancy. But the biggest worry that, of course, we always worry about is the malignant pancreatic cancer.
So we can get into some of the risk factors for pancreas cancer. And so it's important to start out with saying that pancreas cancer cannot always be prevented. There are likely genetic conditions that are associated with probably about 20 to 30% of pancreas cancers. But like many of the diseases that we talk about on the podcast, there are certainly some things that individuals can do to try to reduce their risk. And so we'll talk about some of the more common, well-known risk factors for pancreas cancer. So the two biggest ones are quite modifiable: alcohol and tobacco. And tobacco, so about doubles the risk of getting pancreas cancer. And as Abbas mentioned, alcohol, particularly binge drinking, chronic pancreatitis, is clearly associated with pancreas cancer. There's a clear link between pancreas cancer and obesity and diabetes, and there's clearly some overlap there, as many individuals who are diabetic are also obese. But those are some of certainly the risk factors, and those are things that we can modify. And there's a possible link between processed meats like bacon and sugary drinks. So just that's not been confirmed, but there has been some interesting studies that have shown a possible link between some of those things. So it's so again, there do seem to be lifestyle factors that are associated with the lower risk of pancreas cancer. It's and so it's something that we do have some control over how we can try to reduce our risk of this condition.
Yeah, the pancreatic cancer that commonly we see, it starts from the duct, so it's mostly an exocrine tumor, and based on the location of the lesion, the prognosis as well as the symptoms are different. The one that is commonly in the head of the pancreas, which can cause different symptoms than in the tail. If they are close to what they call bile duct, where the bile drains, commonly jaundice, which people become yellow and start having pruritus or itching. Beside weight loss, those are the symptoms, and sometimes for anorexia may cause depression, and commonly if they're associated with pain, it usually is in the back. By the tail of the pancreas, unfortunately, or the body tail, those are commonly they do not have early symptoms, and by the time we diagnose them, usually have the poor prognosis.
So let's talk a little bit about the incidence of this disease. And so in 2022, it's expected that in the U.S. we'll see about 62,000 cases of pancreas cancer. And pancreas cancer has some interesting statistics, and really some of the really hard. When you hear these numbers, it's just really sad. And when you see these patients with pancreas cancer, it's really challenging. But we're continuing to work hard and move forward to try to detect this disease earlier and get better treatments for it. So it's, in terms of the ranking, it's the 11th most common type of cancer, but it's the third most common cause of cancer-related death in the U.S. And pancreas cancer, the risk of pancreas cancer increases with age, but if you look at the age-adjusted incidence of pancreas cancer, it's actually going up by about 0.5% per year. So it doesn't sound like much, but that's per year. So probably it's estimated by 2030, pancreas cancer will be the second most common cause of cancer-related death in the United States, which is kind of crazy, actually, when you just the cumulative increase in the incidence. And my thought is that that's probably where the lifestyle factors
are playing
a role, because our genetics are not changing by the year. Our genetics change over thousands of years, but not by the year. So it's probably a lifestyle factor: diabetes, obesity, alcohol and smoking.
Right.
Yeah, probably a big component.
Yeah, it's with gastroesophageal reflux or colon cancer, the lifestyle is even more important. But this is such a silent a disease that you cannot do any screening at present times, and hopefully in future we have a better testing to do it that we can catch it earlier, as we do with Barrett's esophagus or colon polyps, and so we will have a sort of a precursor or early diagnosis. Hopefully that would come into the better detection and early treatment.
So if someone comes to you, Abbas, with symptoms of that you suspect might be pancreas cancer, what do they often report? What do you see in the clinic?
Well, commonly, of course, compared to colon cancer and esophageal cancer, these are when they come in. Usually, not all the time, at the later stage. If they're with the head of the pancreas, then of course we look at the imaging to do CT scan or MRI to define how big the tumor it is, and then commonly we pursue to endoscopic ultrasound to see if there's any invasion to the surrounding structure, vessels, as well as we look at the laboratory data such as protein or tumor markers C19-9. So we put all that together, and then based on those findings, then we'll, if it's within the head of the pancreas or if it's small in the tail and is surgically candidate, then we do the tumor conference, as you know, and what the best for the patient is, whether surgery or surgery plus chemo radiation or the palliative procedure to at least prevent them from severe itching as well as jaundice and to relieve their temporary symptoms. So those are all in the decision making that we do with the patient.
And when, as you mentioned, when we meet in these conferences, we call them tumor boards. We often have that conversation about, do we start with surgery? Do we do chemotherapy or radiation? And it really has to do with the stage of the disease. But especially the last 5 years or so, we've been using much more upfront chemotherapy just because with imaging, it's often hard to fully grasp the extent of invasion.
The macro.
Right, exactly. So it's often invading blood vessels that you didn't think it was invading on the CAT scan or the MRI or even the endoscopic ultrasound. And so we'll often use chemotherapy up front, and then after we can treat the pancreas tumor, then we'll remove it surgically. It's interesting though, the pancreas sometimes the tumor doesn't even change size, but it's actually been treated with chemotherapy, but it's almost has a situation, it's almost scarred into the pancreas, and so the tumor actually doesn't shrink, but when you look at it under the microscope, you can see there's been a response to the chemotherapy.
Yeah, pancreatic surgery is so difficult because the location where it is, it's as mentioned earlier, is located underneath the stomach between spleen, liver, and small intestine. So there's many busy area with a lot of vessels, nerves, so the common surgery for that is called Whipple procedure, which is an extensive surgery, but for the appropriate patient, it has benefit, but you do not want to go under this aggressive surgery if the patient is not curative, and then also their lifestyle will change after that surgery as well.
We very much are very selective about when and we recommend pancreas surgery just because of the, as you mentioned, all the lifestyle factors, and it changes the ability to how much a person can eat, and there's all sorts of different changes that occur just from the changing the anatomy of the. Usually, we can preserve a remnant of the pancreas with the surgery, so that person does not need to have insulin therapy. But if we do a total pancreatectomy, complete removal of the pancreas, then the patients have to be on insulin because they're type 1 diabetics at that point,
as well as enzymes replacement for digestion.
Yep.
Of the food, and the diet changes as well. So today is with having the luxury of having the tumor ward and having the surgeon, having the oncologist, GI, nutritionist, as well as other team members to make the appropriate decision for the patient, as well as better imaging. I think endoscopic ultrasound has made quite improvement on the decision making and appropriate thing for the patient, not go for surgery and find out there's extensive disease. So how about some of the newer testing, Rob, that on the horizon? Do you have any comment on that?
There are a couple of things, and so one of the challenges of pancreas cancer is it's often diagnosed pretty late. When someone has symptoms from pancreas cancer, the disease is often stage 3 or even stage 4. Stage 4 is metastatic, the cancer is spread. So what we need is a test that can detect this disease at stage 1. The challenge is that it's not feasible to do CAT scans or MRIs on everybody right now, but there are a couple of technologies that probably will be very helpful for screening for not just pancreas cancer, but other diseases as well. So the first one I just want to mention is something called circulating tumor DNA. So this is detection of DNA that's just floating around in the bloodstream, and from the cancer, it can be identified as related to cancer by what's called the methylation pattern of the DNA. And if this is detected, that person has a very high chance of having a cancer. So there's a company now, it's called Grail. This is not an endorsement. We're not affiliated with Grail in any way, but they are offering this test from your home. You can just get they send you a kit, you get a blood test, send it in, and it screens for, I believe it's 55 different types of cancer. And importantly though, the cancers that are more likely to shed the DNA into the bloodstream are the more aggressive cancers. So, for example, early stage, slow growing prostate cancer or breast cancer may not be a major health threat. That may not shed DNA. However, if someone has pancreas cancer, lung cancer, these are colon cancer, these are aggressive cancers, those are more likely to be detected by this type of testing. So the test is now commercially available. It's not yet covered by insurance, but my suspicion is that this is coming. So in the not too distant future, hopefully even the next year or two, it'll be commonplace for primary care to ask, have you had your cancer screening blood test? And this will be another addition. It's going to be an addition to the current screening guidelines. So we're going to do a whole episode about the new technology for cancer screening. And we'll also talk about the biological clocks that we introduced in previous episodes, about looking at the biological age of an individual. So we'll talk about that too.
Yes, we don't want to be that we are endorsing this test, but we just want to tell you what's on horizon and some hopeful early detection tests in future. So some of the tests, they're not paid by the insurance. They can be quite expensive. And, many people, they have other type of abdominal pain and weight loss. We don't want to go do this test. This is something just general information for future. And of course, for any medical advice, you should seek your primary care physician or your specialty to discuss this. We want to just educate our audiences that there are new technology and new tests are coming, and as well as we have come a long way from CT scan to MRI to endoscopic ultrasound to ERCP, which is injection of dye to the pancreas and the liver, and even these are the imaging techniques. Now we are hoping that in future may be an easier test and detecting through the DNA. So these are not widely available, so we don't want you to run to the physician and ask for this test. These have to be appropriately chosen for appropriate patient.
Yeah, agree completely. And also medical imaging is advancing. So MRI is getting faster and better. So this is also full body MRI is also something that is now available. Again, this is not covered by insurance, but is something that is available. And the idea is to try to detect small tumors. The problem with this kind of imaging is that it can have false positives. So that's always the challenge with medical imaging, is that you may find something, but it may be completely nothing, but may prompt worry, biopsies, and other tests.
Yep. Yeah, we see a lot of liver cysts as well as pancreatics and some renal cysts that before imaging we would not see, and then of course the radiology reported, and many patients that if they don't have adequate knowledge or they're quite go for a toll of worries and stress, and I see that quite common. So with every test it has its own benefit as well as its negative point. So these are what we like to do: educate you that there are hopefully hope for future for early detection of the pancreatic cancer. As other disease that we have mentioned in the past, pancreas and pancreatic disease can be prevented with better choices in our lifestyle. Avoid smoking, excess of alcohol, exercise, diabetes, and preventing disease. As we see with the diabetes, acute pancreatitis, chronic pancreatitis, These all can be prevented to certain extent by making healthy choices in life. Not as much with pancreatic cancer. What do you think, Rob? But still, there's a role for that for prevention as well.
There is a role here, and it's I think this is a disease that is very, as we talked about. We're still learning a lot about it, but clearly there are risk factors that are modifiable: obesity, diabetes, alcohol, tobacco. You can't change your genetics, but lifestyle can be modified, and this is something that we can all start working on every day. So it's I think awareness is important, but also just an education about the risk factors and
inflammation. I think all of these things always start with inflammation, and as well as tobacco and alcohol is probably the highest inflammatory thing that you can do to your body. Processed food and lack of exercise. So I think making the right healthy choices in your life is not for one part of your body; it's a total body, and that including the pancreas.
I completely agree, and it's this is a disease that. It's probably the pancreas cancer and brain tumors are probably our two hardest diseases right now, and in terms of both the early diagnosis and the treatment are both very challenging for those. But we continue to push forward, and we will. I'm sure there will come a day when we have better medical therapies for these diseases, and maybe someday don't even need to do surgery anymore.
Exactly. Well, stay healthy, and thanks for listening. And we'll talk about the new diagnostic in our new podcast, and stay tuned.
Thanks, everybody.
Thank you.